lecturers, Dr. Deepak Govind sir, Dr. Reshma, Dr. Nupur and Dr. Urvashi for having me here. So I will be talking about ventilator graphics. There are two basic forms of graphics, the scalars and the loops. You are on this slide, the scalars are one which are against the time on the x-axis, and the loops are real-time graphical representation of the two variables against one another. So again, as you can see, the scalars are against the time. And remember, these are the shapes of the scalars. And if you carefully look at the flow time scalar, so above one is the pressure time scalar, flow time scalar, and the volume time. So this is exponential decay. This is a rectangular one, this is ascending ramp, and the sinusoidal. These are the four shapes that you need to remember. So how do you know which mode it is? The first and the foremost importance of the scalar is to let you know which mode it is. So can you identify the mode with the scalar, anyone? So remember, in the volume mode, the flow is a surrogate of volume. The flow times scalar is square waveform or rectangular. Yeah. In the pressure mode is rectangular. That are in the pure modes of ventilation. Now we have dual modes of ventilation. They form different scalars, but in the pure form of ventilator, this is the scalar that you will have. See, in the pressure mode, this is the pressure support. This is a different time of scalar. This does not reach the baseline. I will be delving in this in detail. So which curve should be monitored during inspiration? This should be a dependent time variable. So suppose you have set volume control, you should monitor the pressure control, the pressure variable, and in the pressure control you will have to monitor the volume variable. At least that. You can monitor 2, 3, 4 if you have the screens. You can monitor the loops as well simultaneously. It will add to the knowledge. So coming to the first one, the pressure time curve. The pressure curve is always positive during mechanical ventilation. Okay, so why are we monitoring the pressure curve? This is probably the patient is on volume control ventilation, and we are seeing the pressure time curve. So this is the shape of the pressure time curve. And pressure increase during insufflation to reach a maximum at the end of inspiration, and if we give an inspiratory pause, the flow will be zero. So anytime when we give a pause, that means the flow goes to zero and the pressure actually plateaus over the next few seconds. Depending on the compliance of the lungs, it may take a smaller duration or a longer duration, but remember, the flow is always zero. That is how you identify the pause. The flow is always zero, and you can, if the pressure comes to the plateau pressure, I'll be showing you. Again, the pressure is negative initially if you have a spontaneous breath, but it's in the positive pressure ventilation, it's only positive. The two waveforms. If patient is triggering and you have PEEP, it might not go below the baseline, but it might dwell into the PEEP. With the pressure time waveform, you can also say whether the adequate flow is during ventilation or not. So normally it is around 45 degrees, that tells you the adequate flow is there. But if the flow is not adequate, there is scalloping. The flow is set too low, and this is the time, and you can obviously identify it with the loops also. I will be correlating with the loops later on, it will make you easier. So these are the components of inflation pressure. So at the beginning of inspiration, it overcomes the resistance and goes higher to the peak inspiratory pressure. And then when you give a pause, it comes down to the plateau pressure. And the difference between the them is the trans-airway pressure. So here you can identify, this is the resistive pressure and this is the elastic pressure. The P peak and the P flat roughly correspond to that. And patient with normal lungs and inspiratory occlusion of around 0.5 seconds might be enough. But in patients in which they have lung inhomogeneity, you might have to give a occlusion pressure of higher, maybe up to 4-5 seconds also. So usually in the older ventilators, we had an inspiratory pause button in which you had to press them, and then it gradually gives the pause to, you can identify the plateau pressure along with that. So why do we actually need to identify the plateau pressure and the peak pressure? Anyone?
So we have to calculate the driving pressure to see which type of lung we are dealing with.
Okay. So this is a basic graph which we've been learning since 90s and 2000s. So the components are peak inspiratory pressure and the plateau pressure. So if only the peak inspiratory pressure rises and the plateau pressure remains the same, the problem is with the resistance. And if both of them rise, the problem is with the compliance. This is a very basic, and everybody should know at least this much and much more. So This tells you that the transairway pressure is high. So PEEP will elevate all of this by the amount of PEEP that you put. If you put a PEEP of 5, this will be 5. If you put a PEEP of 10, it will be 10. So it will add up to all the pressures. What happens when you give an end expiratory pause? So PEEP is a positive end expiratory pressure, and sometimes the patient do develop dynamic hyperinflation in some states when the expiration is not fully done and develop auto PEEP. So that you can find it by putting an expiratory hold. So by inspiratory hold you find the plateau pressure, and by the expiratory hold you find the auto PEEP. So why are they all beneficial? So these are all components of the pressure. So if the pressure is elevated, suppose the patient is having an increased peak pressure, so you can identify what is the cause by all of these things. So if to distinguish between increased resistance and decreased compliance, the first step is to perform an end inspiratory occlusion. So you have high peak pressure, you find whether the P plateau is high or not. If the P plateau is not changed, it is due to increase in resistance. So it's only the P peak that is elevated. But suppose the P plateau is also high, the change in P plateau can be because of the total PEEP increase, which can be found out by auto PEEP, giving an expiratory pause, or a decrease in compliance. So both of them can add to the increase in P plateau. So you can distinguish them by giving an end expiratory pause and measuring the auto PEEP. Another thing is by looking at the slope. This is a slope of around 45 degrees. You can find out how over time the patient is getting more compliant, lungs are getting less compliant or more compliant. So pressure waveform with a constant slope suggests that compliance is constant throughout the inspiration phase. It has upward convexity. So upward convexity, sometimes called concave downward, means that compliance is increasing during inspiration, suggesting tidal recruitment, and vice versa, which tells you that the compliance is decreasing, the third graph, and it is concave upwards. But it is better seen in the patient over time rather than comparing different patients. So based on this only the stress index came. They gave this equation, and the B in this, the parameter B is called the stress index. So basically it is around 45 degrees, and if B is equal to 1, then the pressure time curve is almost a straight line. There is no concavity and the compliance is constant throughout inspiration. And if B is less than 1, the pressure decreases with time and the pressure time curve is concave downwards because the compliance increases during inspiration. The first one suggests some tidal recruitment. Where if it is more than 1, the pressure increases with time and the pressure time curve is concave upward because compliance increases during inspiration, leading to ignition. And a high mean area pressure may lead to poor hemodynamics. So now obsolete, but HFOV was based on this concept. Now coming to driving pressure, as somebody had told, what is the driving pressure? It is P flat minus the PEEP. So it's one metric of strain applied to respiratory system and tells you about the risk of volume trauma. So there are so many things that you can find out from the pressure time curve. Coming to the flow time curve. The flow is displayed above the zero line, that is positive value during inspiration, and below the zero line, that is the negative value during expiration. And if there is a pause at end of inspiration, it is considered to be the inspiratory time. So inspiratory time is therefore from the beginning of the positive flow to the beginning of negative flow. The pause is taken in the inspiratory time. Again the shapes. So flow waveform is usually decelerating in the pressure mode, and it is square waveform in the volume mode. So let us see the typical ones. So what all can we see? The peak inspiratory flow rate, and then beginning of expiration, exhalation valve opens and it goes down, the peak expiratory flow rate. So total of inspiratory time and the expiratory time give you total cycle time. So this you have to modify and keep in mind in which cases of dynamic hyperinflation, and in which you have to decrease the expiratory time. So remember, inspiratory time plus expiratory time is the total cycle time. And peak expiratory flow rate can be seen in this graph. Again, this is the flow time curve, the constant flow and the descending ramp. The inspiratory pause is a part of inspiratory time. So flow usually has a special shape with rapid increase in flow initially followed by exponential drop. The inspiratory flow is generated by the pressure gradient between the proximal airway and the alveoli. So initially the gradient is higher in the beginning, and that leads to high flow, and subsequently the alveolar pressure decreases gradually during inflation. As a consequence, the pressure gradient decreases over time, leading to low flow. So following the initial peak, the flow drops exponentially, and the dynamics should be talked about by the inspiratory time constant. So inspiratory time constant is the product of static compliance and the inspiratory resistance. Therefore, when the time constant is short, that is either the compliance is low, which is the usual case in things like ARDS, or if the resistance is low, which is hardly the case, the respiratory system will initiate rapidly and inspiratory flow will drop abruptly. So this is the waveform usually you can see in the patients of ARDS. Conversely, if the time constant is high, that is high compliance or resistance, dual resistance is high, the respiratory system will inflate gradually and the flow will also drop gradually. So remember, inspiratory time is when the inspiration ends, and you have to balance it to prevent dynamic hyperinflation, especially in cases of obstructive airway diseases. So some patients in which the expiratory part does not come to the baseline, there is some bit of air trapping, and this is usually the case in obstructive airway disease, in which you have to modify the IE ratio or sometimes increase the expiratory time, and in rare cases decrease the tidal volume or the respiratory rate overall. Again, there is a slow component and a fast component to the expiratory flow. Remember, when the obstruction is there, the peak expiratory flow rate also decreases and the expiratory time is also prolonged. But if the patient actively expires, the peak expiratory flow rate gradually increases. You can also check the response to bronchodilators if you see the patient over time. If you give a bronchodilation, the expiratory part improves, the peak expiratory flow rate increases, and there is shorter time in the expiration. Again, there is the concept of expiratory time constant. So expiratory time constant represents the time needed to decrease the expiratory flow by 63% of the peak expiratory flow. So this is the peak expiratory flow comes down to 63%, that is one time constant. And almost 5 time constants are required for the lung to deflate fully. So you have to keep that in mind, especially in the obstructive airway disease patients. And coming to the volume waveform, generally have a mountain shape. If you give a pause, there is flattened peak at the top. So initial part is inspiration, and then the downward sloping is the expiration. So remember, when there is any air leak, this is on the volume component. So when you suspect air leak, look at the various things when you put the volume component. I will be showing the loops later on, and then we will correlate between the air leak and the volume time scalar, as well as in the flow volume and the pressure volume loops. Loops are very beneficial, and the two loops that we commonly use are pressure versus volume and flow versus volume. So the flow volume loop and the pressure volume loop, this will be talking about in detail. The flow volume loop is recognition of common abnormalities like air leak, autopeak or air traffic, increased air resistance, air secretions or accumulation of condensate. So this is how a normal flow volume loop is there. Flow is on the y-axis, volume is on the x-axis. Initially goes to the peak inspiratory flow rate, then the inspiration finishes, and we go to the expiratory part, the peak expiratory flow rate, and then the expiration ends, and we reach the baseline ideally. Suppose there are secretions and condensate in the circuit. In the expiratory part, you can see undulations. Then if the air trapping is there, the flow does not reach the baseline, and when we have air trapping, it can correlate with the scalars as well as the loops. So we can see that the flow does not reach the baseline in both of the cases, and that is when we think that the air trapping is there. In case of air leak, the volume does not reach the baseline. That is the major difference between air trapping and air leak. So scooped out pattern in case of increased airway resistance. So you can correlate between the scalars as well as loops. When you find a patient with increased airway resistance, the peak pressures will be high and there will be scalloping in the flow volume loops. For inauguration and completing my slides later on. Yeah, we'll be